Brooks, who's back with us.
Let's get started. Please go ahead and put where you're from in the chat. It's always nice. Welcome everybody to the webinar, Treatment Tuesdays. It's the last one in our series, and we're really excited that everybody's here to join us. As usual, we want to thank Southpaw Enterprises for sponsoring this series, and Classy for hosting it. And I'm Suzanne Smith-Rowley, and together with Zoe Mayu, we've had an amazing group of guests, and yeah, and we'll continue tonight, and we have a little surprise for everybody. Okay.
So thank you, Suzanne. And I just want to take a moment to really thank Suzanne for putting this program together. I can say this now because she already spoke, and this won't make her cry. Really, Suzanne just has amazing vision for taking information and putting it together in a way that's so meaningful and important for all of us in this sensory integration arena. And I just appreciate you so much and know how much thought you put into picking speakers and inviting our friends and colleagues to present for this program and for everything that you put together. I know you're working hard on our upcoming Congress that we'll talk about at the end, but I just especially want to say thank you, because I know it takes a lot of thought and effort on your part. So thank you.
Thank you. It's teamwork.
We have an amazing team. Our team at Classy has just been wonderful. We're feeling a lot of gratitude here at the end of the year. So fortunate to have the people around us that we have. And we're so excited to have Dr. Tina Champagne with us tonight. It's so good to have you here, Tina. You can see here from the slide that Tina is the CEO of Cutchin's Programs for Children and Families, and she's an international consultant. She does a lot of sharing of knowledge, both through workshops and through her clinical work, and also by writing. I mean, she's one of these people who can do it all. She's a wonderful speaker, and she writes and shares both in kind of workshops and congresses, but I know also on a personal level with training students and therapists. So we're just so happy that you're here. Of course, she's received many awards, including that she is a fellow of the American Occupational Therapy Association. So thank you for all you do, Tina, as well. Besides being here with us tonight, you've contributed so much to our profession, and just feel really lucky to count you among our colleagues. So with that, we will turn things over to you.
We will, but just let everybody know, don't leave before we do the raffle. And then we've got a little announcement about our Congress at the end. So I'll stop sharing and we'll let Tina get going. There we go.
Okay. So thank you, Zoe and Suzanne and everybody here and everybody who makes this happen. What amazing opportunity. I feel honored to be here with all of you. When Suzanne first reached out to me and asked me to participate, I thought, wow, first of all, a little intimidated because I think so highly of you both. But at the same time, a lot of the work that I do is in the area of trauma and attachment and certainly mental health. And most recently, the bulk of my work is related to working with children and families. Started my career more on the adult side of things, but certainly when you work with children and families, you're still working with adults because you're working with the family as well. So it's kind of all of the above. And in thinking about what I wanted to talk about tonight, given, it's a half hour of time, I was thinking back to, what is it that I feel I could share under the umbrella of AIR sensory integration that folks might be excited to hear about? So with that, you know that the field of trauma and attachment is changing and developing and evolving at a very rapid pace. And just in the last couple of decades, we've learned so much of these areas. And more recently, a lot more attention is being drawn to sensory integration and, more of a holistic approach to looking at what happens when someone experiences trauma in many different ways, and of course, at different points across the lifespan. And so for me, I started to really notice patterns with a lot of the youth that I was working with from a sensory integration perspective, who had what we refer to right now as developmental trauma. And developmental trauma is trauma that occurs, around age 5 or under. And they refer to it as developmental trauma because of the fact that, all of those very early experiences from being in the womb through age 5, not that it's not significant beyond that, but they're really impacting the foundation of the nervous system and one's capacity to perceive their environment, to understand, grow, learn, change, to form attachments, to form healthy attachments versus those that are challenged. And so, a lot of research has been coming out helping to support this over the years. And I started to see these patterns that after I took my certification course with Suzanne and Zoe as part of that training process, I was like, wow, there's just so much. A lot of people were becoming aware of more of the modulation components of what they were seeing, such as hypersensitivities, that kind of thing. But there was this huge lack of awareness and even focus, at least from my perspective, on the other aspects of sensory integration as we know it. So I decided to try to inquire to a colleague of mine who was teaching in university, and I asked her if there were any students that she had that could help me out with a research project I wanted to do. And lo and behold, I got lucky, because not only did I get a phenomenal student named Nicole Sacamandi from Bay Path University. She's long since graduated and works as an OT now. But her mother also happened to have been sensory integration certified and was more than willing to jump in and help me to do a little pilot study, the three of us. So we really lucked out in that way. And so, in this role that I am in now, we have an outpatient mental health clinic. We have residential facilities. We have a special education school. And I was wanting to create and implement a pilot study that would help me to look and see, are these patterns that I'm seeing, can we capture this in a research study? If so, how? Which tests are we going to use? And with the eye to looking forward as to how could we, looking at different sorts of assessment tools, which ones tell us what? And when youth are able to engage in standardized assessment versus when they're much more destabilized and in higher levels of care, are there ways of, what are we seeing in this population, and are there ways of modifying the ability to assess? So these were all the things going through my mind all the time, and practicalities, as well as can we capture this information and really see? So what I'm going to share with you is slides related to this research project. So bear with me for a minute while I share my screen. Can you see it okay? All right. So our hypothesis was that children with developmental trauma have not only trauma-related symptoms, but also challenges with sensory integration that challenge their ability to participate in everyday occupations. The assessments we used are the SIPT. We did the entire SIPT with each youth that could tolerate going through it all. We used the comps, which I'll talk about in a minute, and we used the fine motor component of the BOT. The caregivers, we had complete the sensory profile too, and the short child occupational profile. And the clinicians that were working with the youth completed the child dissociative checklist and the trauma symptom checklist for young children. Now, in my practice, I'm able to do any of these and all of these, but for the sake of getting through this in a timely manner, we split up the job between folks here. So, for example, the OT can complete the short child occupational profile, but we chose to go this route for the purpose of this initial study. The youth that participated were ages 6 to 12, and unfortunately, only 9 of them were able to complete this study in its entirety, but I still feel that the data we collected is important and relevant. So, of course, this is the SIPT. You're all very familiar with these tests. And this is an explanation. This is taken from a presentation I recently did, so bear with me. And we know that the tests break out, generally speaking, into these categories. And this is how the results broke out. So pardon me if this isn't your preferred sensory friendly way of looking at this, but this is the left side of your bell curve when you get your results from the SIPT. So you can see the 0.1 to 1.99 standard deviations on the right here. And those that are in the yellow, I tried to highlight those because those were areas where you saw quite a few of the youth. So the 5 next to space visualization means that 5 youth scored this score in this particular area of this test. And then you can see to the left of that the -2 to -3 standard deviations. And so technically speaking, if you total those together, you'll see that 6 out of the 9 kiddos had challenges in space visualization, and you can kind of go down from there. So this to me was very interesting to actually capture in the data. And this of course was a convenient sample. So we had people who were willing to come and do this. As I said, both of the researchers, myself and the other, were SIP certified. And you can see how the youth did. And I was definitely noticing, and one of the reasons that I wanted to use the SIPT was to try to capture all the different areas of praxis challenges in particular that we typically see a lot of the time. And you can see how the results panned out here. And again, I will say that all of them had significant developmental trauma. No one had autism. And this is information on the comps, and of course on the BOT for those that may or may not be familiar. And our results for those tests were that 7 out of the 9 youth had significant difficulty in motor and postural skills. And then for the comps, and then for the BOT, 6 out of 9 were below or well below average in fine motor composite. And so you can see that this little study really told us quite a bit about our population. And it also helped us to kind of look at, it definitely shows how much more information you get when you're able to utilize the SIPT for sure. And the level of detail to then take to consider different therapeutic interventions. So that is part of what I wanted to share this evening. And for some reason, my PowerPoint won't advance.
If you click the center of your PowerPoint and then try again. I think it's a Zoom feature. Yeah.
Thank you. I'm going to go backwards a ways into this presentation, so bear with me. If visual flashing bothers you, close your eyes for a second. Okay. So where I work, when I first started there, and I started working with the youth from a sensory integration perspective, I started doing so in the basement of our school in their gym. And the gym was in need of a great repair. Let's just put it that way. And there was no, none of the that kind of suspended equipment, no access to any of that. And as you can see, I was working with children that have that significant need. And I would literally both do what I could and then also go with them to outpatient OT, someone local that could give them that extra. And I was there to help with the behavioral support and whatnot. And I got to a point in our organization where I was able to do a capital campaign, and we gutted the gym, and we were able to create this multi-purpose space. So you can see on one side, we have the zip line and rock climbing walls and crash pads. You can't really see, there's a cozy corner nook that's underneath to the side. And then this is a better view of our suspension capacity now. And the hard part is this is still in the basement of the school. And so we do have to take everything down and lock it away and then put it back up the next time we need it. And because this is for, children in our school, in our residential program also that's on the same campus, they all are able to access this particular space when we need to. It's more along the lines of ages 8 to 18. So we also need to make sure that this equipment was large enough, durable enough to be able to sustain what we're doing. And so I just like to show this because oftentimes we hear that we're not able to do these kinds of things in school settings, and we really rallied to make this happen. And it's something that we are able to do and we are able to use not only in the school, but also for our clients in our residential services. And I feel that it's imperative because without the ability to do this work, we're able to see the youth make much significant gains when we are able to add the air sensory integration approach in combination with other approaches for other trauma and attachment needs, depending on the youth's ability to participate in these different types of therapies. So it's always a combination in the work that we do. And a lot of things depend in part on the youth's ability to engage, how stabilized that they aren't at any given time. And as we know in the field of trauma, it's very important to make sure that we include that huge emphasis on the body that's very, very prominent in all of the literature at this time in the area of trauma. And so when you're able to offer, at times we're not able to do really comprehensive assessment first. Sometimes it's starting off with just being in this space with the kids, as you all know, and that's part of your clinical observations and whatnot. But being able to have this, I just wanted to share with people to show it is possible to do these things. It is not always easy, but it is definitely possible to do. In addition to that, of course, we have utilized other kinds of therapeutic interventions, everything from clinical aromatherapy types of things to different forms of therapeutic approaches that are focused more on trauma and attachment. So it really depends on the youth. It really depends on the family. It depends on where they're at. As much as possible, we work with both the client and the family from the attachment perspective. It's not always possible depending on, the route. Certainly in patient, we are able to do that much more often and consistently. So yeah, that's pretty much what I wanted to share with everybody, and I'm happy to open up for questions.
Thank you, Tina. Your work is so vital, so important. There's there's a question in the Q&A. I don't know if you can see that.
Let me get out of the sharing of the screen.
Okay.
Mhm.
And then there are also, I think, some questions in the chat, but if you need help, if you want us to read it to you, we can do that. Or if you look down at the bottom of your screen and look at Q&A, there's one
How do
question
you
there.
educate the staff?
That's in the chat. Go ahead and answer that one, and then I'll copy this other one into the chat for
Okay.
you. That's probably easiest to see it there.
How did I educate the staff on the importance of this work? Well, this is never work that's done. In the field that I work in the types of settings, we have almost constant staff turnover. And so, especially now these days, it's hard to even recruit staff, let alone hang on to staff. And so it is a constant. So we have in our orientation to staff when they come in, we have woven in an introduction to this way of working. It's all part of our trauma-informed care approach. And so under that umbrella, we begin that process, and it's very much the basics. And then, you know, which program we're talking about. We also make sure that we work in the ability to tie it to whatever therapeutic approach that particular program uses. So one of our programs uses the DBT, dialectical behavior therapy. One uses the ARC model, attachment, regulation, and competence. Another one uses the Bruce Perry's model, the neurosequential model of therapeutics. And so we try to really integrate those models as much as possible and try to use that language also. And, you know, over time, you start off with more basic trainings and then you continue to make it more and more advanced as you go. And so I have some staff that are very well versed and other staff that are just beginning their journey. And so there's the general trainings, but there's also the modeling as well, and having OT in all of these programs, which we are able to do in Massachusetts. There's a strong support for that.
Okay, thank you. I'm just going to, let's see if I can enter this. Oh, it's not working. There. Okay, so I just put in the chat the question that was in the Q&A, and there's another question in the chat related to adoption. So maybe you can look at this first one if you, either I can read it or you can read it. And
Sure. Very early trauma like early adoption that is straightforward, and those that are not. What difficulties have you seen? And can early intervention be provided to help? Will there always be a sensory deficit to this? So several questions in one. So very early trauma in adoption. There's never anything straightforward about it. So I'm going to back up, and I think I'm interpreting what you're saying, asking me correctly. So sometimes people who have adopted children who have experienced a lot of trauma, it could have even been in utero, and maybe they adopt the child really early in infancy, and then you see these quote unquote behaviors emerge over time. And a lot of times families have a lot of guilt over that because they think, well, we adopted so early, you know, are we somehow responsible for this? And there's a lot of data out there to show that trauma that happens early in utero does have oftentimes these lasting effects, let alone if there's additional trauma after that. And so when that occurs, it can oftentimes have an impact on the nervous system in such a way that the infant and or youth has significant difficulty with how they perceive their environment, how they perceive the caregiver. They don't have the cognitive capacity to override those, you know, strong neurophysiological responses. to fight flight and whatnot. And so, you know, you can very often see significant difficulty with the attachment relationship occur. And when the, you know, the caregiver isn't having that reciprocity of being able to feel like when the child is struggling, that they're able to comfort that child, it begins to have an effect on them as well. And so, you know, right from the get-go, that's one thing that I would that topic. And then of course, early intervention services can be helpful. When people ask me the question about, you know, will the effects of trauma be long lasting, and will you have this for the rest of your life? I always go back to my knowledge from the body of science, of nonlinear science, where we are self-organizing systems. And while I can't say that every person is going to be able to have a full recovery, at the same time, what I have seen is when we're really able to provide really comprehensive assessment. And that's from all of our different areas of the teams that you work with. So from the OT perspective, you saw my research. So clearly I'm promoting sensory integration is a significant portion to this, which I think has been left out of the picture for a very long time. I think we're only more recently able to demonstrate through different aspects of the literature how important it is when you have a caregiving system that is able to have the supports that the caregiving system needs. That's not only with the caregivers or the parents or whatever family system the youth has, but also the actual providers as well can be coordinated and really wrap around. Even if those providers change, come and go, and because that does happen, if that unit can stay really tight and continue those services, I have seen significant progress happen. And so I'm a firm believer that in the recovery process, and it's more about what I just explained, and also trying to help to minimize any continued traumatic exposure that the person might have. And sometimes that's, you know, a matter of education, training, the kind of support I'm talking about. But other times it could be things that are out of our control, like the pandemic, like, you know, natural disasters. You know, I was working with a young girl who had experienced all kinds of trauma. She was only 5 years old when I met her. Her feet barely hit the floor. We had done a lot of work together. She had come a long way with her whole team. She had a team like what I'm talking about in a foster family as well. And we were making huge strides, and a tornado touched down in her neighborhood. And you saw, you know, this huge, you know, a lot of dysregulation and whatnot. But the difference is we were able to then get back, you know, get back to the therapy and continue forward. But sometimes it's a bit of a back and forth, right? And sometimes the youth that have some of the most extreme trauma and attachment situations, they also have bio parents or other folks that are coming back in and out of their life as well. So again, that's why this idea about these teams that can help to wrap around and to provide that comprehensive assessment, reassessment, and continue working together from all these different lenses, so critically important. And that, I believe, is at any age, but especially with young ones.
You know, Jane Kumar was working on those safe spaces, and I think she had published on that, and she was working with a team of psychologists and looking at what those kind of sensory motor spaces, these kind of clinic environments like you were able to set up was really allowing the children to experience their bodies in another way. And I know a book that was really influential to me was The Body Keeps Score. And I think that's, you know, that, you know, holding on you know, inside somewhere. And then when you are able to have those integrating sensory motor experiences, that things get better, they feel better. So it certainly doesn't take care of all of the aspects of trauma or attachment issues, but I was feeling like it was a nice place to begin. Like you said, even before you're able to do an assessment, to give them these safe spaces where they can play.
Yes, definitely. And that was a lot of the rationale for when I was working inpatient with adults very early in my career. My own brother had a first psychotic break, and right when I was a brand new baby OT, and he was admitted into a setting similar to like I was working on. And whenever I realized, wow, there's so much more we can do, that's what gave me the idea to have the sensory spaces within these psych units, and you know, really working on that and in the most simplistic kind of way. At first, just even focusing more on modulation to start, more of, you know, regulation, I should say. And so having the clients, because that was adults, so having the clients help to identify things to have in the spaces that would be helpful to them, that was approved to be in an acute inpatient unit. And then of course it went on to forensics, and that from there had a whole life of its own. For people that know of my work, artists, that's, you know, one of the places that that different sorts of sensory motor groups, there was a lot that we were doing at the time. And back then we were much more limited in assessment tools we could utilize with adults outside of clinical labs and things like that. So it's kind of like, you know, that's how I sort of entered into having this focus. And of course, when I added entering into the world of children to my career, that's when I sought out my own certification in sensory integration. And it just was like, wow, okay, now I get it, because I was 6 years old. I'm 6 years older than my brother. And I was able to look back with that new lens and go, wow, there was so much that was missed from a mental health perspective. And so, yeah.
Well,
very eye-opening.
and I have another question for you. I know there may be other questions, but I know in our clinic environment, we are adjacent to a mental health suite who refer kids. And sometimes when we're doing our work, you know, maybe a more traditional ASI approach, suddenly things emerge from the children that sometimes
Yes.
go beyond our ability to know what to do with. And, you know, we've been so blessed to have these mental health practitioners that can provide us some support. But what do you do when suddenly there's a reveal, or a child suddenly has a breakthrough or breakdown that you know is really intrinsic to their mental health?
Yes, and this happens a lot, especially in the populations that I work with. And so I'd like to first say that this has been a huge invitation for OTs to make sure that, you know, and depending on where you work and depending on how many other kinds of professionals you have, everybody works in a different place, but I've always only ever worked in mental health. And so, you know, I've been blessed to have been able to take many, many courses and to advance that aspect of my practice as well, looking at trauma and attachment. And I know that there are OTs out there that oftentimes feel that that is going outside of their scope, but this is where we started in the profession, is in mental health. And so it is another aspect of your practice that you can grow. Certainly similar to sensory integration, there's different, you know, levels of how would you call it? You know, you start off as a novice and you work your way up. So it's similar in the area of trauma and attachment. And so I think it's important that OTs look at ourselves as qualified mental health practitioners as we are trained, but also realize the areas that we want to get more and more skilled in. That said, I have had many kids, everything from starting to feel more present in their body, and therefore they start to dissociate because that doesn't feel like a safe space, to children actually remembering and starting to talk about and or act out and or use art supplies to share their story or stories of what happened, that their version of what they recall happened. And in those situations, it's extremely important to stay present, to not become alarmed yourself, because the last thing that you want to do is have them feel they can't share that, just even if it's just by your body language. So you want to stay supportive, you want to stay present. It's also another good reason to have the caregiver present whenever possible, because then you have another person there to help comfort the child, and just be an active listener, hear what they have to say, and help to comfort them. I will always say, I will validate them. I will say, I'm so glad that you were able to share that, how brave you are to share that. And let's think about, sometimes we were able to get to the point of let's think about who we want to talk to about this. And other times it's more about transitioning and or pulling in another provider if that's available or possible. But I would, really be careful to not demonstrate in your own body language or what you say that it's not okay to share that with you, because again, who knows when and if that child's going to go there again, if they feel, because they oftentimes, when you have really significant trauma and attachment, your core sense of self is typically one that you feel shame, you feel like you're a bad kid, quote unquote. Your core sense of self is not one that is necessarily positive. And so you just can't know how they're going to perceive, they're trusting you to go there if they're not able to. There are times when I've had to file 51As because I'm a mandated reporter. And that's never a comfortable thing. And so, when someone starts to access their body, a lot of times people feel more grounded at any age and more safe. And there's times when they have more access to memories, or they have more access to what's happened to them, or if their body doesn't feel like a safe place for any given reason, then that can also sometimes be challenging.
Right, I have one more. So doing evaluations, I do a lot of evaluations, Tina, and so often, when the school age kids come to me, it's OT for handwriting, or they've heard about sensory something, and the diagnoses are autism or other health impaired. But when you get into the history, sometimes you see that there are there was an adoption, or they were in foster care, or that there was, sometimes it's buried in the historical documents, but it doesn't appear to be front and center,
right,
in most of the record keeping that I see, unless it's really dramatic mental health issues. So, I mean, how do we bring that forward sensitively without creating a dramatic situation, but also highlighting, like, oh, look what happened in early childhood, look what happened in the first 2 years or 3 years, and that would have an impact, for example, on executive functioning.
Right. Well, for me, and it's hard for me to kind of, everybody that I see has something going on, and they're usually willing to say, although some kids' records are sealed by DCF or what have you. So sometimes I don't have a lot of information either. Or sometimes you just can't get it because of children coming from, different places, different countries, who knows. So, if it makes sense to go there, then I go there. If it doesn't really make sense to go there for any given reason, let's say when they're coming to us, it doesn't seem to be coming up or playing a role in the here and now, then I don't necessarily feel the need to go there unless, as I'm working with the child, doing assessment, working with the family, I start to see things that make me think, maybe there is a connection here. Because sometimes, and I'm also looking in the chat here, sometimes, as has been said, there doesn't appear to be specific trauma, or maybe it was a trauma that was acute. And the attachment relationship is really solid. And so maybe it isn't that has brought forth some of the developmental challenges that we're seeing. But, it doesn't mean that if you feel that it is possible that it has, that we wouldn't mention that. It's always tricky and a delicate subject to talk about. And I always try to talk about it in a way that the caregiver and the child, depending on the age and how involved they are in these conversations, but that I do so in a way that I always assume that they're coming from a place of feeling shame and like they did something wrong. And so I try to be as validating and as caring and as nurturing as possible. And rather than, well, this happened and this happened, and so that's probably what led to this, very frank kinds of conversations. So I go into it delicately. I find that it's hardest to have these conversations with people who have a lot of intergenerational trauma. And although someone may have not had, also related to the questions in the chat, it may appear that a youth that was adopted didn't have trauma. There is this thing called intergenerational trauma. There are genetics. It's hard to really know, how we come to be in the differences that we have that show up. And so there's all these different things to think about. And even if a parent is really, really stressed when they are pregnant, we're now starting to see more and more, how some of that can impact the nervous system. And, even in my own kids, the 3 kids I have, they're all completely different in how they process sensory information. It blows my mind. My son is the most sensitive of all of us, and the girls are aloof and not. And, so like, and they all came from the same mom. And so, when you look at all the possible things that can happen, as parents and in families, and the more we learn about trauma and attachment, you start to realize how little we know, like with a lot of things, right? And so it's important to always have that in the back of your mind as something that could have been a thing. And everybody's different. So, some people will experience the same exact trauma and have one response, and other people might have a completely different response. So there's no cookbook to it. So I always start with where are they at when I stabilized or destabilized are they? Are we really working on helping them to just stabilize their nervous system in the beginning so that they can be more accessible? As we do that, what do they tend to seek? What do they tend to avoid? And start to kind of explore that a little bit, depending on the age of the individual. I may use more or less language in that exploration, and just try to take it really one step at a time.
Yeah, in the Q&A, there's a couple of people asking, what about medication, and what methods do you use? What do you actually do with the kids?
Right. I let the psychiatry work out the medication. We're oftentimes giving them as much information as possible that helps them to guide them in that. So, and depending on the presentations, and in terms of different interventions, it just depends. as I said, I am open to a lot of different things. I love air sensor integration, and I also am a person that will also utilize a lot of different modalities. Certainly as an occupational therapist, I want to use occupation-based approaches as much as possible, but there's many, many times when the whole reason they're coming to services like mine is because they are struggling to be able to do that. And so it's more preparatory as we start to get things going. And then, over time, adding more and more of the occupation base. So we have all kinds of things that we utilize, and it depends on what the youth is, what their interests are, what we're working on therapeutically. So anything from, the therapeutic use of horses to, setting up obstacle courses. You can do that with just about anything. It doesn't have to be fancy and expensive equipment. Helping kids to create their own safe spaces, even if it's in their room, in the residential setting, in a corner of a room, or actually helping us to create and or keep updating very specific spaces that we have. Going for walks, bike rides. We're located alongside of a bike path, so that's always handy. Gardening, all kinds of different things that we have that are available. And so kids can jump into those things or decide to do other interventions if that's what they're into. Art, therapeutic expression, self-expression.
And I
could go
think
on.
because we're kind of nearing the end of our time, I do, just like, and the kids get better. Are you hopeful? You see those children
yeah,
in
definitely.
recovery, and yeah.
And they tend to have a much better chance at that when we're able to help them with, developing that nervous system and getting more stabilized. And as they become more stabilized, helping them to work on those attachment relationships to the best of our ability. We oftentimes start that with, sometimes even it's like parallel play with the caregiver and the youth, and then have it be non-threat, and we're the authoritarians if we need to be, and helping them to just enjoy each other, find anything that they can do together that they would enjoy to do together, because oftentimes these relationships become so stressed, they haven't experienced joy together in a long time. And, or it might be minimized, for any number of reasons. And so helping the caregivers to focus on their wellness, which I know is where we're going to go into next in your discussion, and also us too as the caregivers, right? As caregivers for our, taking care of ourselves as well, because it is very hard work, and the ability to stay present and stay grounded and not, it's very common to have vicarious traumatization or compassion fatigue when you work with this population a lot. And so really being mindful about that for ourselves as well is super important. And then we're modeling that also for the families and helping them to realize this is natural to experience stress, and that, this is hard work. And so maybe with that,
Yeah, with that, thank you so much. One of the questions was, where do you go to get more training as an OT in trauma and attachment in the work? I think, honestly, I really feel like we all need it, because you never know the little person coming through the door where they've been, and some have seen a lot for their young years, and even the adults or their parents who are trying to stay healthy. So if you could maybe put some ideas.
Sure. Well, I think most people know that I have trainings that I do. Kelly Maller in the world of interoception has started to do trainings in anything by Bessel van der Kolk. Let's see, Maybe I'll, while
And
you're
Tina, yeah,
talking, I'll
we could
type them in.
also, we could attach something to the replay when we put the link. So maybe we can get some things from you and add that.
Sure.
Yeah, well, as Tina mentioned, while we were thinking about this, and also, you know, to thank everybody, we put together a little list. It's a present for everybody, all of you. Let me share it, because we were thinking these are gifts to give ourselves. So thinking about wellness and wholeness, and we went into the neuroplasticity literature. So these are evidence-based strategies for a happier, healthier life for ourselves or our clients. You know, starting with ARIS sensory integration. Did you want to say something?
I was just
Tina?
going to say, Suzanne, that Marco just put the link in the chat. So if anyone's feeling like, oh my gosh, they're going to try to take notes or something, you can just click on the link and follow along, and you'll be able to print this as well.
And you are welcome to download it and share it with all your families and your friends, and take it out and look at it and remind yourself, put it by your mirror and remind yourself. Because I was thinking there are simple things we can do every day. And you know, the neuroscience is pretty clear that we can change our brains. You know, sensory integration is essential to adaptation and resilience, and ongoing neuroplasticity. And I think that that's what we want for our clients. That's what we want for ourselves. And I just love this quote by Dr. Ayers, that sensory integration is based on the study of the vertebrate brain. We all have vertebrate brains. So she didn't think that sensory integration intervention was necessary for everybody, but there's no getting around the fact that we are sensory beings, and that our brain is the ultimate organ for adaptation. And so in addition to the genetic gifts that we have and critical periods in our brain development, we have enrichment, right? So we all have that developmental or experience dependent neuroplasticity. So here's some of our ideas. And again, the references are here. You can look at their work. I really encourage you to do it, because it's a beautiful body of work. And I don't know, Zoe, if you want to, we won't have time to go over every single one, but if you want to pick your favorites.
This is a good party game, huh? Well, I don't know. I've been very focused on gratitude lately, and I think in our profession we naturally have so many natural opportunities to see the challenges that humans face, and I think that we can pull from those experiences to feel gratitude so often. So I think I'm just grateful for having that awareness and having that opportunity in my profession to look at human resiliency and see what kinds of things people overcome. And so I'd have to put gratitude and laughter at the top of my list. I think that's a combo that will always make me feel like I'm a little more balanced. And
Okay, well, so I'm going to nerd out a little bit in the neuroscience. What Huberman found in terms of neuroplastic change with gratitude is, yes, we can be grateful, and that's a good idea. He said, but in one study, what they found is that the bigger changes occurred when you were experiencing somebody being grateful to you. Okay, so the act of gratitude towards someone, and they were able to replicate it when you were watching a video of people doing kind things to each other. And I think that that's so magnificent. Isn't that interesting? I mean, yeah, we can all be grateful, but when someone says, hey, look at what you did, you did something really great. Or if you see somebody like, you know, these really heartwarming stories we're going to all be watching over the holidays with our family. But I thought that was an interesting little piece of neuroscience. Of course, laughter. Laughter's wonderful. Let's see, what was my favorite? I'm going to go back to arousal. I guess this is still Huberman. I'm liking his podcast. He's he's cute, first of all. And second of all, he's really smart. He's from Stanford. So it's easy, he's an easy listen to.
Can you invite him to our Congress?
He's just up the street.
Well, what
Well,
about that?
I haven't thought about it, but yeah, he would be fun. But he's got a lot of just little things to make you healthier. Like go outside, and he's a student of Huber and Weasel. Okay, do you guys know Huber and Weasel? He did the visual neuroplasticity. That's his pedigree. So anyway, he said, go outside and look at the environment, like put your screens down, put your phone down. When you're taking a walk, look at the sky, look at the tree, look at the birds, because that visual stream has direct connections into your arousal system that lowers your arousal and has a calming effect for you for the whole day. Who knew? You kind of know, but you still get caught like looking at your toes or looking at, like the things, your phone. And then he was also talking about the rhythm, the daily rhythmicity that we have. And I know Zoe and I were talking about sleep, and I don't think we had to stop somewhere. Okay, we didn't get sleep in here, but that rhythm, okay, getting rid of all this blue light, a little bit before you go to sleep, get that blue light away from you in those nighttime hours. And also he said, your rhythmic system, your brain likes consistency. So he said, the more consistent you can be in terms of your sleep cycling, the better you're going to sleep. So you can get into deep sleep. And then, then of course, enjoy your wakefulness and be active during your wakefulness. And he thinks being active, getting some exercise in the first couple hours after you wake up, it's a really nice idea. So just a couple of little tidbits.
Again, thank you for putting that together, Suzanne. I think we just have a couple minutes, so we better get to our raffle.
All right. So as I said, you guys are welcome to have this. Thank you, our supportive community. You're the best. So, okay. So I'm going to turn it over to Marco.
Thank you, Suzanne. And we have our winners for tonight's raffle, the last one. And I'm going to share my screen so we can see the names as they pop up. Can you see my screen?
We can.
Yes,
but not the names. Right.
No.
Okay, the Easy Starter Kit winner is Kathleen Gusky Sharp, and I apologize if I didn't say that right. Kathleen, please email Melissa. I'm sure Melissa will drop her email in the chat so any minute now. And congratulations. And our softball winner is Cassandra Salmons. Congratulations, Cassandra. Congratulations both, and Merry Christmas. Here you go. This is a very nice present.
Yeah, and happy
Thank you.
holidays.
Happy holidays to all of you.
All right. So last but not least is just to remind you that our webinars are done for this year, and we won't have another series starting soon. We don't know when the next series might be, but we are going to have a big party in July. It was meant to be for Dr. Ayer's 100th birthday party in July of 2020. Of course, that got postponed, and last year didn't seem very prudent. So we are going forward with it July 14th through 16th in 2022. And we have an amazing lineup of speakers and research, and we will be inviting posters. And if we can, we're going to be in person. And if not, we will move to virtual.
Well, thank you again, Suzanne and Southpaw, for sponsoring our Treatment Tuesdays, and to our whole Classy team for all of your support. And Tina, that was just a great presentation, a wonderful discussion tonight. Thank you again for sharing so much of yourself.
Thank you.
Thanks for
All
inviting
right.
me. Thanks everybody for being so wonderful. Happy holidays.
Thank
Happy
you.
holidays.
Okay, be
Okay,
well,
bye.
everybody. Stay connected.
And
Okay.
Happy New Year too.
Happy New Year. Bye.